Hi. Hello and welcome to Knock Knock Hi with the Glaucomfleckens. I am your host, Dr. Glaucomflecken.
And I'm your co-host, Lady Glaucomflecken.
Oh, we're excited that you're here and are going to spend some time with us today. We have a fun show for you. Dr. Eric Topol's going to be here.
Yes, he is so interesting.
Yeah, we have been reading up on artificial intelligence in preparation for having him on. And I've learned a thing or two about a lot of different things. He knows a lot more things about all this stuff. And so
all the things,
all the things.
Yeah.
And so, you know, it was a fun conversation with him. Before we get to that, we just got back from a trip. We were in Florida. Went to Fort Lauderdale.
Mm-hmm. Had a speaking gig.
Yeah, and in Miami, spoke at a primary care conference, and it was great. It was a fun trip, except for the fact that you had a rotting tooth in your mouth.
Well, now it's not rotting. Get your facts straight.
Why don't you tell everyone what you had here?
All right. Well, so I did go to the dentist.
Like the day
before, the afternoon before, we were leaving very early in the morning for this cross-continental plane ride, because I was having a lot of tooth pain, and you're the one with the sensitive teeth. My teeth hardly ever bother me.
This whole thing just gives me shivers, and
this is my chance to get revenge.
I don't handle teeth things very well. I hate the dentist.
Sorry to all
the dentists out there, but your job sucks. Anyway, go ahead. The scraping and no. All right, go ahead.
Okay, so it was giving me pain, and there was like a bump forming. So I was like, this isn't good. I need to go get this checked out before we leave, just in case it's something horrible. And it turns out maybe not horrible, but not great. The tooth was broken right at the root, just all the way across, just clean break. I have no idea how it happened. Dentist said usually there's like some impact trauma and people can tell you why, like when and where that happened, but
thinks you're going to blame the dog.
I have no idea.
Maybe
Probably the dog. I mean, that is one of the things that the dentist said can cause this, and that does happen.
We have a big
dog. A dog will paw you in the face sometimes. But there wasn't like a particular time. But this particular tooth has given me trouble over the years. It's got a crown on it. It's had a root canal.
And they wanted to do surgery to fix it.
They wanted to have me the next day. Yeah, they wanted to have me come in the next day and have it extracted, and I get to have a bone graft. Yeah, got that to look forward to. And then once that heals, put in an implant. But we of course had.
You were like, no, I'm sorry, I have to go speak as Lady Glaucomflecken in Florida.
Well, that's not really how I said it or what I said, but I did say, is it possible that we could wait a few days? Because I knew we had that speaking gig, and then we had this interview with Dr. Eric Topol, and I did not want to miss either of those things. So we're putting it off until in a couple hours. I gotta go and
right
get
after we finish this, she's going to get her.
But I spent the whole time.
Tooth
removed. We talked to what she said. I think almost 2,000 people at the conference, and we were a keynote, and they had the camera, and we were like big on the screen, and I spent the whole time just hoping that my tooth would not just fall out on stage.
Because it's very loose in there.
The only thing, you'll love this. The only thing still holding it in is the root canal.
Okay.
It would have just fallen off because right at the gum is where it's broken.
Oh,
so
I'd rather have a cardiac arrest.
Well, you did, so I guess there you go.
Yeah. But it didn't. It did not fall out on stage.
It didn't,
thank
and
God.
it didn't fall out in this interview. And here
it's still
I
there,
am.
and you're about to get it fixed.
Still here.
And so
last time you'll ever see this, baby.
Have fun with that. All right. Well, let's enough. That's enough about the teeth. All right. Let's talk to Eric Topol. So Eric Topol is a very fascinating guy.
Yes.
He is the professor and executive vice president at Scripps Research.
Translational Institute.
Yes, founder and director of the Scripps Research Translational Institute, and has done so much. He's had a very impressive career, a lot of other accomplishments as well.
I think he's like literally written the book on AI in medicine.
And deep
Many
medicine.
books,
And
actually.
he's got a lot of several books, and so many more books than I've probably read in like the last 2-3 years, because I don't read that many books.
It's a low bar.
Books. Yeah, you read more books than I do.
I try. It's hard when you have kids these ages.
Yeah.
People know.
Anyway, let's get to it. We're excited about this one. So here is Dr. Eric Topol. Dr. Eric Topol. Thank you so much, Eric, for joining us. It's always a pleasure. I got to talk with you not too long ago on your podcast you were doing, and so we're happy to have you on ours now. So thank you so much for being here.
I'm thrilled to be joining you, Will.
So I was in kind of researching you a little bit, and I was listening to a few interviews, podcasts you've done, and I heard something a little bit alarming. I heard that you haven't used a traditional stethoscope in years. Is that right?
It's really true.
What do you use as a cardiologist? That's surprising.
It's like blasphemy, I guess, right? No, I carry the stethoscope in my coat to look good, so I can pass as a cardiologist. Well, I haven't pulled it out for as long as I can remember. The reason is I now use a smartphone ultrasound probe. I used to use a handheld device called the V-scan, but that was replaced by all these smartphone probes. So now every patient I see in clinic, I do a echocardiogram, and it's great because hearing lub-dub isn't really as insightful as seeing everything and also showing it to the patient. So within seconds, just with a little gel on the tip of a probe, we're looking together at a smartphone and seeing everything you could imagine about the heart. And it's really great because the number of people I have to send for an echocardiogram becomes very minimal, but the insightful information is extraordinary.
Well, you and I have something in common. I also haven't used a stethoscope in years, but I'd say I have a little bit more of an excuse as an ophthalmologist. But do you see that being impacting medical education? Because, obviously, a big part of learning the clinical exam is, learning all the lub-dubs and all the other extraneous noises that you hear. And I assume that's not going to go away, but, and this has some applications with ophthalmology too, because we're such an imaging-based specialty. But do you see things moving in that direction where we're all carrying around echoes?
Yeah, that's one of
handheld
my
echoes?
mistakes is that I thought we would have been there years ago. I thought that we would have immediately seen that the stethoscope is obsolete. I mean, it still is useful. Like if you're going to intubate somebody, you're just checking quickly for breath sounds, or you're trying to listen for blood pressure, for the sounds. But, I used to be a fanatic about teaching medical students and interns and residents to hear paradoxical splitting and all the fine sounds and the bedside exam. But the bedside exam now is done through ultrasound. And of course, it's not just for the heart, it's for every part of the body. And I think, except for the brain and perhaps the eyes, but,
well, depending on who you talk to.
Yeah. All the body is so amenable to high resolution imaging, and we should be doing that. The problem is, it actually has a much better acceptance in the developing world because they're not so fixated about reimbursement, and they have hunger for leveling the playing field of technology. So the other thing that's really cool about it is now you can use the AI to help you acquire the image without even knowing what the hell you're doing. So, an 8-year-old like my grandson,
or an ophthalmologist,
could actually obtain an echocardiogram, which is the hardest one because of all the motion. It says, move up, move down. As long as you know, like, which is the left side of the chest, and the patient doesn't have situs inversus, you can actually get an echocardiogram without even knowing what you're doing, and then get it interpreted with AI. It's wild.
And it's what's interesting to me, AI and kind of this type of advanced imaging, it's an active area in ophthalmology because especially with diabetic retinopathy screening, I'm sure you are familiar with some of the AI work going on in that area, especially in third world countries. It's actually some places they're really on the forefront of kind of introducing AI with screening for diseases that affect the retina. And I have always thought that we really need this in our country a lot more, especially in emergency settings, because nobody knows how to look in the back of the eye anymore. Unless you're an ophthalmologist, you don't get that kind of training. And so, I would love to see that in the eye space as well.
No, you're absolutely
Um,
right. Ophthalmology is leading AI. India is a pioneer in diabetic retinopathy and retina screening with AI. So yeah, I mean, this is so much. The other thing just to note is the retina is the gateway to the body, so that the picture of the
mhm,
retina or OCT of the retina, I mean, you can learn so
mhm.
much about almost every system of the body just from that snapshot. It's amazing.
I'm impressed. You threw out OCT there. You're familiar with the OCTs.
Oh
So
yeah,
this is
well we do
a
we do OCT of the coronary arteries, but OCT
that's
of the
true.
retina, oh that's big. I mean,
Yeah. So these are,
I'm
for those
impressed.
people who don't understand, OCT is a really high resolution where you can get a cross sectional view of the retina, and it's especially useful in diabetic retinopathy and other diseases that cause swelling in the retina that are related to cardiovascular health. And so, being able to uh, have widespread imaging available for this is just really helpful. I can tell you how many times I've been on call and just I really wish this was present in the emergency department. And I think that's probably the future. I think we, just like you have, a handheld, ultrasound that you're kind of going around and showing patients. I would love to have that, the ability to image someone's retina.
So, for the record, I hear that you're saying that you would like to have the ability to ultrasound the eyeball. That's what I
Well,
heard.
it's like a traditional ultrasound is a little bit different. So, Eric, I don't know if you're familiar, but there's obviously in the emergency medicine world, ultrasound is very important, and so it's a tool that they use frequently, especially with eyeball stuff. And so
Mm.
that's something I'm talking with emergency doctors about a lot, and it can be
He
helpful in
picks some
certain.
fights
I
with them about
do,
it.
I've gotten drawn into some arguments on social media. You're probably very familiar with the some of the pitfalls that come with social media because you have a
Oh
pretty good
yeah,
social media presence as well.
right, no question.
But what I wanted to do, I want to stay on this AI topic, especially with Chat GPT. And so I hope you don't mind. A lot of the questions I'll be asking are generated by Chat GPT. Is that okay with you? I'm just
Okay,
kidding.
yeah,
No,
sure.
no,
That'll be
yeah,
interesting.
it would be. But I'm curious what your thought is on this, because it seems like the topic of AI has really come into the public consciousness a lot within the past year, in part, it seems, because of GPT. Everybody's playing around with this tool. And so I'm curious what your thoughts are about this tool and how do you see it kind of in the overall picture of artificial
And
intelligence?
have you ever asked it what it thinks about you?
Oh, I haven't
Yeah.
done that yet. That's a good one. I think it's really interesting because obviously it is the craze now, and everybody's talking about
Hmm.
not just Chat GPT, of course, but this whole large language models. I kind of see it differently than many people. I just see it as taking what we had with deep learning, which the only way
Hmm.
we got to deep learning was having the graphic processing units that we've got from video games to manage, massive amounts of data, and the ability, and that was using supervised learning largely, where you had to have the images, mainly images that were uh, basically got ground truths with expert annotation in
Hmm.
medicine or any annotation outside of medicine. And so that together formed the era of deep learning. And what this basically is that on steroids, where you have computing power taken to the nth power, handling trillions of parameters now, even hundreds of trillions of parameters, and you got GPUs, the likes of which we don't generally have in most places. That's why, in some respects, OpenAI had to join forces with Microsoft, because Microsoft's got a lot of GPUs or TPUs with the case of Google to work with. So I see it more as big expansion of computing power, and the big difference is we're no longer relying on supervised learning. It's unsupervised, self-supervised. So basically using
Right.
tiny amounts of pre-training and letting the computing power do a lot of the learning. So what we now see is not just images, but what of course is fascinating people is that you take text to
Right.
images and video or speech, and I'd say present this in the style of Dr. Glaucomflecken, and and tell jokes and all of a sudden it sounds like, but of course it's kind of the
Are
way
you saying
it's.
I'm going to be replaced, Eric? Is
Well,
that what's going
simulated,
on? Are you...
emulated. It's a great form of flattery. But no, I think that what's amazing here, of course, is when it hits, it's stunning because it's using context of large language input, but it's still got a ways to go. I mean, GPT-4, which is forthcoming, and
Yeah.
Sparrow and all these other ones, whatever we're seeing right now is just going to get better. And so I do think ultimately it's going to have both the two-edged sword of advancing a lot of things and introducing lots of liabilities too.
Tell me about those liabilities. I'm kind of curious about that.
Well, the fake stuff. We live in this world of blurred truth and fact-free, and it's definitely going to exacerbate that. And so, having avatars that look like any one of us, that talk just like any one of us, and say things
Kinda
that
like the
we never
deep.
said,
Yeah.
we're going to be
Right.
seeing that. And so the fakeness, no less the errors and the
Yeah.
misinformation. We live in a terrible era of mis and disinformation, and this just provides tools to take that to yet another bad extreme.
And so,
How do
well,
you see that affecting medicine, and what can we do about that?
Yeah, that's a great one because I don't think we're anticipating it as well as we should. Um,
right.
with AI hasn't really made that big a dent yet in medicine. I mean, basically, it's lots of algorithms in radiology and a few other specialties. Lots otherwise, it's mainly in the research domain and publications and whatnot. But as it gets more and more into it, and so for example, we see it's a way to liberate from keyboards, and so all of a sudden, doctors are no longer data clerks, and their spirits are uplifted because the conversation is now virtually scribed, better notes than what we got, even with human scribe, no less, with doctors
Yeah.
typing it themselves. And of course, it picks up the orders for tests and the next appointment and medications and codes, and does it all the stuff that replaces the clinician. However, what happens when that goes cuckoo? When we have glitches and when we have
Yeah.
deliberate hacking, and the whole idea is, why would we ever have to deal with pre-authorization anymore? We would have the chatbot do that for us. But what
Right.
happens when this all software is glitch prone, and then take that to another level is when you have deliberate adversarial attacks. And what
hmm
we don't have in health systems now is any surveillance. It's like trusting that the AI is going to work um, in perpetuity. Well, maybe not. So these are some safeguards
Right.
that are just not there yet, and so we haven't seen the adverse potential, but we have to be anticipating it.
hmm I'm curious too, how health insurance companies are going to come to interact with AI, and what that's going to lead to. And I mean, probably nowhere good, I would think. Do you have any thoughts about that?
Well, the first
Yeah, I
thing
imagine they don't. Yeah,
you start thinking about the
yeah,
chatbots talking to other chatbots. It's going to be really
Yeah.
right.
interesting
Well,
because they're going to have their algorithms for not covering things, which is what they're so well known for.
Exactly. That's kind of what I'm
Uh,
thinking of.
yeah,
Yeah.
and
yeah,
the doctors or the people in working with doctors and nurses. I mean, they're going to have their version. So it's a collision of algorithms. No, I
Yeah.
mean, it remains to be seen, but clearly insurance companies are going to be heavy into this because
Yeah.
right.
their efficiency, as you know well, most of the workforce in healthcare in this
Hmm.
country and most industrialized nations have been in non patient care people. They've been all these administrative people that deal with things like insurance providers, and
Hmm.
Right.
we can't coders and all these things, back office operations, and of course that's what largely accounts for ridiculous costs of healthcare. So we've got to do much better.
Hmm.
This is a way to get there, but it remains to be seen, how well it'll work.
Yeah. Do we
Yeah,
see insurance companies investing in these spaces yet, or is that it's
They
happening
move very
already?
I'm sure
Yeah.
slowly.
they
They
are.
they move like a
Yeah.
battleship, and changing direction.
Right.
So United Health was kind of on a path. They had a very progressive strategic group, and then they got all let loose. So they were going kind of backwards. Blue Cross Blue Shield, not yet. I think maybe CVS, Aetna, because they're kind of trying to do big things. But none of the big ones yet have done anything of substance so far.
And on the healthcare professional side, so much of our time and effort is in getting the documentation just right to be able to send to United or Cigna to say, hey, this patient needs this test or this treatment. I've crossed all my I's, dotted all my T's. So you have to imagine that that's
Hopefully you
something.
did that the other way around.
Cross my T's, dotted my I's. Did I say that wrong? Hey, yeah, 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 yeah. You get what I'm saying. Hopefully, maybe AI can do a better job of that than I can. But that's one obvious thing that you can think of would be helpful is making sure you have that documentation right in order to maybe decrease the amount of insurance denials. But then on the flip side, it's like, well, now you're just you're putting so much time and effort into I guess you still have insurance dictating what you're doing,
Yeah.
and that's a
Clash of the
frustrating thing as
algorithms, like you're
well. And
saying.
so
Right, right.
yeah, it's it is kind of scary. It seems like this is all progressing so much more rapidly than we know what to do with. Like, it's almost like we're flying blind, it seems at times.
Yeah,
It's like
I
we're
mean,
not sure.
it all, the signal of the large language model era really only was felt in the last few months, and it's going
Mhm,
to get more. Um, obviously it wasn't set up to do the things you're just talking about, to
mhm,
basically go through all of a patient's records and tee it all up, and
mhm.
we're going to see this happening undoubtedly in the next year or two to a substantive level. So I think there's a lot of potential here as long as we keep our guard up that it's not something that the human in the loop part is going to be
Right.
critical. Whether it's in actual care of the patient or these ancillary aspects, that's never going to go away. The importance of it.
I'm also interested in how this might, both the language learning models and AI in general, how it can affect medical education. Because I don't know if you heard that Chat GPT just recently passed step one,
Yeah. Yeah. Well.
which, yeah.
Yeah. Well, first of all, when you if you only need 60% to get passing to pass the U.S. medical license exam, that doesn't seem like a very high threshold, right?
True.
60%.
It's just
So,
step
yeah,
one. That's why there's so many steps.
yeah,
It's
yeah. But
also
of course,
classically, yeah, one of the harder
so
ones.
both Google's Palm, MedPalm, and Chat GPT's both did that recently. And
Yeah.
yeah, I mean, I think it's interesting because the part of memorization of
Hmm.
of the deets, the details. That stuff is, of course, going to be comparable or better in computing than humans. But
Hmm.
it's all the human stuff that we need to emphasize more, and we haven't done that yet in education. Medical school, as you well know, it's what
Yeah,
was your grade point average and what was your score in your MCATs. And unless you do
exactly.
adequately on those, you don't even get past square one. So we cultivate brainiacs that memorize really well and are interpersonal skills, communication, presence, trust, empathy factors. I hope that's going to be highlighted a lot more because the
Yeah.
support of us in medicine with computing is going to keep getting better. But are we going to keep emphasizing the things that are not as important? I don't know.
And it's also uh, a big focus. I know in the work that you do is making time for us to cultivate those things, that were a part of medicine, years ago, that have gone away in the time of kind of increased demands on a clinician's job, and pulling us in so many different directions with our time.
Yeah, so
And
you're speaking specifically of like the time with the patient,
yeah,
doctor-patient
Right, right.
relationship.
yeah.
Exactly. Yeah. Well before you two came into the world, when medicine was a very different era. When I was just getting out of med school, late 70s, early 80s, there were typically a very precious, intimate relationship, that patient-doctor relationship. You always knew the
Hmm.
doctor had your back, and, you could get in touch with that person to help you in any situation. And they listened. They didn't interrupt you within seconds, and they had time, much more time, multiple, 4 or 5, tenfold time to sit with you. And we
Hmm.
don't have that now because of the big business of medicine, and it eroded steadily over the years. And we can get back to it. The gift of time that you referred to is the ultimate to me of what AI could bring us if we really push on it. It won't happen by accident because we have overlords that want us to see more patients and read more scans and slides and whatnot. So it has to be that we work together to advocate for the getting the relationship back to where it was, or even better than it was.
Do
May-
you, do you,
maybe I'm just cynical, but it just seems like with an ever growing population, it just seems really hard that we could ever get to that point again.
I, I,
Because
yeah.
I don't know.
you could be right. I try to be optimistic that
I like that.
a lot of
We need people like you. We need
well,
optimists.
a lot of the simple stuff is going to be algorithmically supported. So if it's a ear infection of a child, or skin infection, or potential skin cancer, urinary tract infection, a long, long list of stuff that will be
Hmm.
determined, screening doctorless with
Mm.
algorithms, persons capturing their own data, and then a lot of video visits for routine things that are quick, and just saving the important meetings when you in person, when it's
Right.
big stuff. So I do agree with you that with the increasing comorbidity and burden the population, we have to come up
Hmm.
with new ways to address this, but we have to think about that relationship which has been
Right.
seriously
Hmm.
hurt over time.
Do you think that the erosion of that doctor-patient relationship and the loss of time together, um, and the subsequent loss of trust, perhaps that brings, do you think that has contributed to this epidemic of misinformation now, especially in the medical realm, and that maybe if we can repair some of that, that we could get back to a little more, like you said, we're living in a time of blurred truth. So, do you think that this could help that issue?
Absolutely. And I think it's essential. Used to be that clinicians were regarded as the most trusted individuals, and that's taken a big hit over time. Partly because many patients feel that they don't get the kind of attention, care, the true care
Mm.
that they deserve and need and want so badly. So I hope that will come as you suggested. Yeah.
Yeah. And maybe also breaking down some of the silos that exist in medicine. That's one thing I've noticed, from the patient family perspective. It's not very interdisciplinary right now, and sometimes that can make things, inefficient at best and really problematic for the patient at worst. So hopefully this,
Being able
the
to
use
care
of
for
AI will.
families as well, or
Yeah, and it just, you have to have 5 different appointments with all the different subspecialists, and they don't communicate very well across specialties. And, it can just introduce, an additional burden onto the patient, let alone it gives opportunities for human error and for information to fall through cracks. And potentially
yeah.
nobody's seeing the greater pattern that might exist, especially in some of the more complex, diseases. So it sounds like this could be promising in that kind of area as well.
Yeah.
Absolutely. I mean, I think getting different discipline expertise in the room with a patient and the patient's family, when that's appropriate, is part of this gift of time that is essential, rather than, having these multiple appointments with redundancies and, all sorts of things that are unnecessary. So yeah, if we're going to do this right, we know what it takes, and having transdisciplinary um, fusion of effort is really critical.
Well, I'll tell you,
Yeah.
I would have a lot more time if I just spent less of it on TikTok.
Can it help with that?
And so I don't know, Eric, if you have TikTok on your phone. If you don't, I highly encourage you to avoid that.
Okay, I
It's
haven't
a
done
it's
that
a
yet.
okay.
I
All right.
yeah, but I know you have a big presence there, along with the other social media. I mean,
Well,
your sense of humor in medicine is unprecedented, and so yeah, TikTok would
oh,
be
I
great for
appreciate
you,
that.
right?
Well, I honestly think that social media, I mean, because you have a big following on social media too. That's the first time I actually heard about you was on Twitter and seeing some content come through. So, and I think that's going to continue to be more important just because that's where patients are. And I think there's actually a lot of AI work that's going to hit social media as well, and like predicting virality, like what makes something go viral, what are the things that people are paying attention to. And I think that's important for healthcare professionals because that's where patients are. And
Yeah.
so and we need trusted healthcare voices to battle all that
Yeah, social
misinformation.
media is kind of an extension of the doctor-patient relationship.
Yeah, yeah.
In some respects, and the problem we have really is we don't have many choices there. You know,
Hmm.
when Twitter has been threatened with how it's going to run and get politicized more, and then there is no other real platform that you can reach to patients and help to provide good information. So
Yeah.
hopefully over time we'll either see better alternatives, or the ones that we have will be more functional and less. Um, I think unfortunate right now is that we've seen some troubling aspects of Twitter, where bringing back some of the masters of misinformation. Okay, that wasn't particularly in
Yeah.
the midst or the tail of a pandemic. It's not the kind of stuff we really need.
Yeah.
Well, let's take a quick break and then we'll come back with Dr. Eric Topol. Big thank you to all our listeners. Spread the love. Share this podcast with everyone right now. Go. Share it. Share now. Let's do it. Leave a rating and a review. You can be honest with us. I've been on social media long enough. I can take the criticism or the happiness. If you want to give happy thoughts,
Yeah,
that's
we
good
like
too.
it when people share their happiness.
Later today, we're going to share some of your own medical stories. You can share yours, knockknockhi@human-content.com. We have a Patreon as well. Hang out with other members of the Knock Knock Hi community, early episode access, check out bonus episodes, including this whole other monthly show that we do where we react to medical shows and movies, like anything from House to MASH to Monty Python, all kinds of stuff. Next week, we have a new monthly eye exam coming out. All right, so look out for that. Now let's get back to Dr. Eric Topol. All right, we are back with Dr. Eric Topol. So, Eric, I wanted to just do something here, which I think might be kind of fun. Maybe not. I don't know. I assume it's going to be fun. So it's this little game that I call, Can AI Do This? Can AI? I'm just going to throw out some things, and then we'll talk about whether or not this is like an actual thing that can happen with the use of AI. Maybe now, maybe like 20, 30 years from now, maybe we'll be able to tell the future. I don't know. But one thing, whenever the topic of AI gets out there, especially on social media, there's always some talk about replacing physicians, replacing healthcare workers. Is that ever in your mind a possibility that some kind of doctor, ophthalmologist, radiologist, internist could ever be replaced by AI?
Yeah, I
What are your
really
thoughts
don't
about
see
that?
that. It may, to some extent, limit the growth of a specialty. But, when I tried to put a lot of thought into this when I wrote Deep Medicine, and radiologists were the ones that were, the father of deep learning. Jeffrey Hinton says we don't need them anymore. Well, guess what? We do, because obviously you don't want to trust an algorithm that to interpret a scan that could be determining a patient's life or death. But more importantly, this gives an opportunity for specialties like radiology to take on things that they haven't done, which is actually talking to patients, because they're the ultimate, potentially, honest, independent broker. Like, do I really need this surgery? Um, or did they really want to live in the basement in the dark and have patient contact? But also, what about all these scans that are
Yeah.
done unnecessarily with radiation exposure? Shouldn't they be more gatekeepers? So any way you look at it, there's a way for that specialty to take on other facets of care that they don't necessarily today. So I don't see any specialty being X'd out, but it is possible that that with the support, augmented efforts of AI, that we wouldn't need as many. Or, when I did the UK review, it was more, can we get away without having to, train a gazillion more specialists, that kind of thing.
Hmm. Well, as basically what I'm hearing is, as long as the humans are smarter than the
Yeah,
AI,
and also most of us,
we can.
there are exceptions, but most of us would rather entrust the physician with a key decision rather than the output of the AI.
Yes.
So that human in the loop factor. Now, I know some people, particularly computer scientists, that say they rather trust the algorithm, but I don't think that's the typical scenario.
Based on what I've seen from Chat GPT, I think we're safe
Right,
in a lot of
right.
ways. So, all right, here's another one. All right, can AI make internal medicine rounds more efficient? That's a hard sell. I know. Do you think we can cut down on rounds by a couple hours at
Oh
least?
yeah,
I don't know.
no
What are your
question.
thoughts?
Well, especially, think about the poor medical student or intern resident that has to go around an hour or two before starting at, 5, 6 in the morning to get all the data
Yeah,
together with yeah, pre-round. Oh, the
pre-rounds.
Pre
AI will do
rounding, yeah.
that much better, of course.
That should be the
Yeah,
first
also,
thing to go
also
away.
in the
That should be the
rounds,
first thing
where
to go
the
away.
people that are trying to be, the show-offs about knowing the literature, the AI will have a total command of the literature to that moment. So no, a lot of that stuff will change. And so, yeah, I think that's a great opportunity that rounds will be infiltrated with support of AI.
Because right now, a lot of, at least right now, I say that it's been like eight years since I was a part of internal medicine rounds, but there was a lot of, oh, let's, stop for a second and look this up. Let's get on up to date. And so, are we moving to a world where you can just, you know, verbalize a question and then it's there? Or maybe AI is listening to rounds and pulls up, automatically kind of brings in information into the conversation in real
Oh,
time.
it
I
would.
don't
I
know.
mean, just like
I don't know.
you're bringing up really good points. So, the attending would say to the team, what is in the differential diagnosis? And the chatbot will, after they've all talked about it, well, you haven't considered such and such, and the probability of that's 38%,
Yeah,
and here's
right.
why. Yeah, absolutely. And even the attending
Oh my
didn't think
God.
of it. So sure. One of the things that we have to respect is we make a lot of diagnostic errors, and that's where having command of
Mhm.
all the data and all the literature we can be supported for that. Be better, sharper. Yeah.
And that was going to be my next ask about what AI can do is, can it help us to diagnose like some of the more complex, the rare diseases that, like you said, maybe we're not thinking about, connective tissue diseases that are sometimes
thinking
really
EDS.
like EDS or other things that are just more difficult to diagnose.
Idiopathic cardiac arrest.
Yeah, I've heard of that. Yes.
Exactly.
Yeah.
Yeah. That's
like,
that's
why do
another
those
thing.
happen? We don't know. Maybe
Right.
AI can figure it out.
Like what I've learned through my recovery from my cardiac arrest and talking with other survivors, it's actually relatively common for young people to not really have an answer.
This one drives me nuts
Yeah.
because we have almost 97% of the people who have a defibrillator put in never use it for their life, the rest of their life. And how can we be that dumb? And then all the people that should get a defibrillator who then have this arrest who don't have
Mhm.
that benefit. So we have to get smarter with that. And that likely will happen when we understand all the things like, the genomics and the image processing and, all the pieces, the so-called multimodal AI. So I think we'll get much better. But yeah, our ability now, the problem is when we don't know a diagnosis, we send a patient for every lab test known to mankind. We do these,
Mhm.
hunts that are absurd, that are very costly, and also taxing to the patient, sending them for, this and that. And we can cut down a lot of that, waste and kind of rabbit hole stuff.
Mhm.
And we can be much sharper
Yeah.
about how we process a possible, entertain the differential diagnosis.
Well, I think part of that, though, it might be the human element. Like we're afraid of things we don't know and we don't understand, and so I think maybe part of the reason we do these workups is because we're chasing after uh you know extremely rare diseases. And so could AI be this, I don't know, in some ways more a more detached observer that is just looking at the
Yes.
statistics of, okay, this X% chance of this, and so it's not worth it to
Yes.
do this $1,000, $10,000, $100,000
Exactly.
workup.
No, I think that's where
Okay.
the long tail of all these, unusual conditions and syndromes and whatnot, that's going to be a big
Hmm.
plus because unless you've seen one of them or you're familiar with it, you
Yeah.
easily could miss that diagnosis. Sure.
Well, another one that we talked about a little bit already is, can AI eliminate insurance claim denials? I have my doubts. I think they're going to find a way around it.
Yes.
And
I think we're going to put
so
a dent in it
I
though.
don't know.
I think the
You
burden
think so?
of teeing that up on the clinician side will be less. Whether they'll be able to
Do you think it'll make
uh,
it?
no, whether
Oh,
they'll
sorry.
be
Go
able to
ahead.
ante up is going to be interesting. But
Right.
Do you think that'll make it a little more transparent, though? I mean, if it's all going to be algorithms, going back and forth to try to beat who can deny what, somewhere someone has to be able to read that algorithm. So, do you think that it's going to make it a little bit easier to kind of learn the strategies that are being used to just deny everything? And, I'm thinking of that ProPublica article that just came out. Um,
Looking at the inner
Looking at all the
workings
different,
of
yeah,
the
it's gonna
insurance
make the
companies.
the inner workings maybe a little bit more visible because it has to be literally written down somewhere in
yeah, we have to
code.
crack that
Yeah.
code. Yeah,
Yeah,
That's
I'm
true.
sure they will
right.
protect
But
that
but
with their
I
lives.
think the insurance companies are their reputation that has been so adversely affected by denying people's coverage that they are entitled to. And so, I think the momentum with this power of AI will help to some degree, but we'll have to see how it plays out. The power of insurance companies
Yeah.
is overwhelming. Obviously, it probably couldn't get worse than it is. So I always try to, my default is to have some optimism that we can improve this.
Oh
But
man.
I share your concern.
Yeah.
I'm with you.
I hope to God you're right. I hope it can't get worse. And the last thing was just, again, with this, something we kind of touched on earlier. Do you think AI can make medically themed comedy skits? on TikTok?
That's a good one.
I don't know. I
Well,
guess we'll find out, right? That might be the last thing, because there's so many more important things for AI to do.
I think the reason is
Maybe after all
but
that.
training from you, it's going to be, it's got powered.
Yeah,
Yeah.
you'll be the
they're
input
gonna
to the
be looking
AI.
at all your
Wow.
TikToks and all
Oh
your
man,
skits, and
I'm gonna.
That's way too much power
yeah.
for you to have.
I'm
We're in trouble.
I'm replacing myself. There's probably AIs
Well,
listening
is
to
there
everything I do now.
a specialty you haven't hit yet? Because I'm sure it could have transfer learning for that.
Yeah.
Yeah, right?
Actually, that would be really
Help
helpful.
with your research.
I haven't
Oh,
hit
there you
plastic
go.
surgery yet.
Mm.
Yeah, I need that. I need AI to help me with that. And
Get a lot of radiation. What is it?
radiation
Radiation
oncology.
oncology. Yeah.
I'm missing the specialties that I have rarely, if ever,
Right.
interacted with. Now, I've interacted with
Yes.
cardiologists a lot.
I'm aware of that.
Yes, so
Shows in your content.
that's my go-to. If ever I run out of ideas, I know I can always hit up cardiologists for something. So
That's right. Well, it sounds like it's a good time for doctors to get a side job in computer science or learn some computer science. 'Cause it sounds like maybe there will be some new job opportunities opening that we need physicians to be able to, help these
That's a great
algorithms get
point for
developed.
everyone to get at least some knowledge. I
Yeah.
think this is going to take more place in our lives than a lot of people envision, and have to understand the nuances, not necessarily, how to code or getting deep into it, but, just what if its potential limitations, the caveats are really important.
well, thank you so much for joining us, Dr. Topol. Eric, this has been
No,
a pleasure to
I thought you were
so
going to
finally
ask me
get
my
to
most
pick your brain.
embarrassing event.
Oh, yeah.
I
let's
had it
hear it,
already
please.
for you.
Absolutely.
So, all right.
Let's do it.
Okay,
let me
so
hear it.
let's go back
Absolutely.
to 1984, long time ago. So at the time, I was
Well, not too
oh,
long ago, Dr. Topol, because you see,
yeah,
that's
there
the
you
year
go.
I was born.
Right, that's what I mean, a long
So.
time ago. Uh,
That's right.
so
Oh, no.
anyway, I'm at Johns Hopkins, the cardiology fellow, and I was very much involved early in this clot busting drug called TPA, tissue plasminogen activator. And so we treated the first heart attack patient ever with TPA in 1984, February 1984,
wow.
almost to the day of this interview.
Really?
And
Wow.
anyway, Johns Hopkins wasn't really known as a heart attack center. And so they wanted to have a press conference that we treated the first patient in the world with TPA. And because I
Yeah.
was a fellow that had been working hard on this, I was part of the press conference. Now, in those days, we had to do a cardiac catheterization first and take a picture of the artery to show the blood clot.
Okay.
And then we could give the medicine in the vein. Of course, eventually that led to you just give it in the vein from the cardiogram. You didn't have to have the angiogram first. But remember, this is the very first patient. So the most embarrassing thing that happened to me ever in my history of medicine was at the press conference. So the Baltimore newspaper, the Baltimore Sun, the normal journalist, a woman, was sick that day, and they sent in this guy who'd never done any medical story, or maybe any story for all I know. So he says, "Well, Dr.
Oh my gosh.
Topol, how do you do this catheterization, and how do you do all this?" And so I explained it to him about we put a catheter in the groin and numb up the groin area, put the catheter in the groin, and, take pictures of the artery. So in the front page of the Baltimore Sun the next day, it said, Dr. Topol explained how the catheter is inserted into the genital tract and snaked into
Oh,
the
no.
heart without any pain for the patient.
Oh, no.
And little did I know, I had invented the field of urocardiology. And a day in infamy. So anyway, I learned a lot
That's
from that
awesome.
experience.
Oh,
I learned
man.
that you have to be really
Oh.
careful how you communicate to journalists who don't kind of look at you like, "What's the groin?" Maybe you should say, "No, the
Yeah.
groin is not the genital tract." But anyway, I thought I
Well,
thought you.
you've given me a great idea
Oh,
for a
good,
skit.
good.
Thank you. I
I thought you'd
appreciate
like that
that.
story because it was terribly. Can you imagine the people that contacted me after reading this article? Oh, yeah,
Yeah.
yeah.
Oh, I bet you
No,
didn't hear
no,
the
and
end of
then all
that for a
these years
while.
later, I still hear about that one.
Well, it made you the science
Oh
communicator that you
gosh.
are today. So there
Oh,
you go.
a good tough start.
Are you happy with
Tough st
are you happy with where TPA is now? How many
Yeah,
years later? Like 40 years later
Oh,
yeah.
now, right?
shush, you. No, we're not going to say how many
Almost
exactly.
40. Yeah.
Almost,
No, I mean,
almost.
it kinda gave way to, just opening the artery with a balloon catheter directly over time, but at that time, that wasn't really, in play, but it's still being used to treat heart attacks and strokes, along with other clot-dissolving medicines, but, it was a very exciting time to be, in medicine, but and also to learn
Yeah.
about how you can make big gas without even trying. Yeah.
How, how did the first we'll say the first 10, 15 patients you used TPA
It
on?
was
How did
actually
it go?
amazing because we didn't even know what the freaking dose was, and most of the clots opened up. So the funny thing you're asking about is, and this is what's so crazy, when you inject the artery with dye, it's under pressure, just shooting dye. So we probably were opening some of these arteries with the dye, well, not through the medicine. So we were
Oh.
helping it. You see, we were like massaging it for the low dose
Yeah.
of TPA.
Yeah, yeah.
So it was working like in almost every patient. And then, so we thought, well, gee, this thing's really potent. And we could, getting the right dose and figuring out this whole equation of, when you just give it in the vein and you don't have a catheter in the artery. We had to learn that. It took a while. It took more than the
Yeah.
first 10 or 20 patients, but eventually we got the right dose. But it just shows you how when you do a contrived
Wow.
thing where you have this
Yeah.
extra aspect that wasn't part of the practical way of giving the medicine, it buggers things up and it obfuscates what's going on.
Wow. That's great. I love that story.
Yeah. Who knew?
That's awesome. You know what? We're gonna keep you on actually for we have a couple of fan stories.
From
So
our listener mailbag.
so we'll take a quick break. We'll be right back with those. All right, we are back with Dr. Eric Topol. So, Eric, we have a couple of stories here. We want you to listen to these with us here. So, the first one is from Riley. So, Riley says, we've always joked in my family that my dad, a classic ortho bro, is the worst patient. I'd say most doctors are
Yeah.
really terrible
Very
patients.
bad.
He rarely gets sick, but when he does, he absolutely refuses to be taken care of. He was particularly non-compliant as a neuro ICU patient. It's probably not the
No.
place you want to
No.
have trouble there. After waking up and getting extubated, he started demanding that we give him a syringe. My mom and I were confused, but he was adamant about getting that syringe. We asked his nurse if she knew why he was so fixated on it. He wants to take out his Foley, she said. My dad didn't know what year it was, but he knew he wanted to take out his own Foley catheter. Obviously, no one ever gave him that syringe. He made a full recovery. And so we constantly tease him about his antics as a
Well,
belligerent
I'm
ICU
impressed with
patient.
his cognitive state rather than just pulling the darn thing out without
Right?
taking the balloon down,
That's an
Yeah.
excellent point.
You know what? I don't think I've ever told you this, Kristen, but
Uh-oh. Oh, no.
when I woke up in the ICU,
Yeah.
that was one of my first thoughts.
To take out your Foley.
No, was do I have a Foley catheter? Because that's like something I've never wanted to have, and I remember like thinking, oh no, what's going on down there? Do I have what's my situation going on? And so I probably would have been very much like this doctor.
I'm sure you would have.
All right, our next story comes from Ava. So or Eva, sorry if I got your name wrong there. So there was a previous listener story about cockroaches that were found in a call room. And so this prompted another story from her. So before I started doing urgent care, I was trained in family practice and worked in a small rural practice in Maine. My partner says that while on call, he received the following phone call from one of his older patients. Doc, I'm out at my hunting camp and I just drank a pot of coffee. When I went to make another pot of coffee, I discovered there was a dead mouse at the bottom of the coffee pot. What should I do?
No.
My partner says he was so taken aback that he paused and said nothing, not sure how to answer. The patient then said, don't worry, doc. If I grow fur and a tail, I'll call you back.
Was this a farmer?
It sounds like a farmer. But this just ends this note by saying, I can't help but wonder how you cannot taste essence of boiled mouse in this situation.
So gross.
This the mouse was cooked in with the coffee pot.
Hopefully it was
in
very
there.
hot coffee.
Wow. Yeah.
There you go. Not sure what kind of infectious diseases you're opening up with that situation, but that's a little outside.
To figure that one out.
There you go.
That's right.
Ask it what to
AI can
do
help us
when
that.
you drink boiled mouse.
So if you guys have any stories, send us your stories at knockknockhi@human-content.com. Dr. Topol, Eric, thank you so much for joining us.
Oh, I really enjoyed it. Keep up the great work
So
you two are doing. And what a thrill to have a chance to have this conversation, hopefully many more in the years ahead.
Oh, at some point,
I hope.
I want to hear more like TPA type stories.
I
I'm
can
sure
come up
that
with a few more, I'm sure.
You've seen a lot of medicine over the years, and so. But again, thank you for taking the time being here.
Thank you.
We really appreciate it.
We'll see you next time.
Bye-bye now.
Bye-bye. Well, that was great. That was fun to talk to
Yeah, so
Eric
fascinating.
Topol. He's just so knowledgeable about so many different things in medicine. So,
And there was so much more we could have talked to him about and
I
didn't even
know.
scratch the surface. So maybe we'll have him back on sometime.
so do you have any stories to share? We would love to hear them. Please share. I love hearing the stories from people because there's just so much of that. So many weird things. A mouse at the bottom of the coffee pot. What would you do in that situation?
Oh, scream. Throw the coffee pot.
Yeah.
These are just things I know about myself. Those
Fortunately,
two
you
things
don't
would
drink
happen
coffee.
immediately.
But I don't know what I would do.
And then maybe try to
I
make
wouldn't
myself
feel
throw
great.
up. I think I would try to throw up.
It would, yeah. That would be a decision to make. But at that point, it's like it's already going through your system. I don't know.
Yeah.
That's something you'd probably like wake up in the middle of the night thinking about.
Well,
though,
he
like
didn't
years
seem
later.
too bothered though.
Yeah, I
so
guess
hopefully
so.
it all turned out all right.
Tell us what you know about the episode today. Tell us what you know. Tell us what do you know about our episode. No, what do you think? Do you know somebody, another doctor who or any other healthcare professional who could come on and chat with us? There's lots of ways to hit us up. You can email us knockknockhi@human-content.com. Visit us. I'm having trouble talking all of a sudden. Visit us on our social media. We are on YouTube, TikTok,
Twitter.
and also you can hang out with us in the Human Content Podcast family on Instagram and TikTok at Human Content Pods. Thanks to all the great listeners out there giving wonderful feedback and awesome reviews. We're in the beginning stages of this podcast, so it's nice to get that feedback. If you subscribe and comment on your favorite podcasting app or on YouTube, we can give you a shout out. So we have Hobgirl79 on Apple said, I am a current medical scribe at a children's ER with various medical career experiences over the last 20 years. Planning on applying to medical school in 2025 and really love listening to this show. It really rings true to my experiences and is a great to listen on my way to work. Keep up with more podcasts. I will continue to listen and tell others. Thank you so much. That's
Yeah.
very kind. And congratulations on applying to med school and on being a Jonathan.
That's right.
So all of our episodes are on YouTube, full video episodes every week on my YouTube channel at Glaucomfleckens. We also have Patreon, lots of cool perks, bonus episodes where we react to medical shows and movies, hang out with the Knock Knock Hi member community. We're active in it, posting videos, polls, jokes,
Pictures,
comments,
videos.
all kinds of stuff.
You said videos.
And I did, but more and more. Early ad-free episode access on Patreon, interactive Q&A live stream events, lots of things. Patreon.com/Glaucomflecken or go to Glaucomflecken.com. Speaking of Patreon community perks, new members shout out, Laura Lee M, Betsy H, Maggie S, Joan I, Corin B. Thank you, and welcome. Also shout out to the Jonathans. We have Patrick, Lucia C, Sharon S, Omar, Edward K, Abby H, Stephen G, Rosk Box, Jonathan F, Marion W, Mr. Granddaddy, Caitlin C, Brianna L, and Becky. A virtual head nod to you. Patreon Roulette. This is when we take a member of the Patreon emergency physician Patreon level and give you a random shout out. So I'm going to do my little
drum roll.
My little drum roll. Shout out to
Joan I.
Joan I for being a patron. Thank you, Joan I. And also, thank you to everyone for listening. We are your hosts, Will and Kristen Flannery, also known as the Glaucomfleckens. Our special thanks to Dr. Eric Topol, our guest for today. Our executive producers are Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brook. Our editor and engineer is Jason Portizo. Our music is by Omer Benzvi. To learn about our Knock Knock Hi's program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, you can go to glaucomflecken.com or reach out to us at knockknockhigh@human-content.com with any questions, concerns, or jokes.
Or
Jokes. Or puns.
Preferably
if you
puns.
have to. I'm not a big fan. Knock Knock High is a human content production.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.